United States, mainly from Boston. Dr. Mohamed Fouda, the GM of Oncology, Pharmaceutical Diagnostics. USA, he will talk for us about AI in healthcare with oncology updates. Is our speaker joining? He's joined the link.
Can you hear me?
Yes. Good morning, Mohamed.
Thanks for the invite.
Thank you so much. Can you share your presentation, please?
I'll share my screen right now.
Thank you. Dr. Mohamed kindly agreed to join us, and it's 4 a.m. in Boston, so he dedicated this time and he woke up very early to join us. Thank you so much.
Sure, absolutely, no problem. It's an honor to be with you today. Thank you for the kind invite. Ain Shams University holds a special place in my heart. I have a lot of friends there and a lot of mentors, so it's really great to be with you all today. Can you see my screen? Can you see my screen?
Not yet. We're waiting. They're working on some technical issue.
Okay.
Yes, we can. You can go ahead. Thank you.
Sure. So thanks again for the invite. It's really an honor to be with you today. So let me start first by sharing a patient story, because I think patient stories put things in perspective and really tells us why do we care about AI in oncology. So I'm going to use a hypothetical name, but it's actually a true patient story that happened 5 years ago. Her name is Sarah. She had non-small cell lung cancer, and she progressed on chemotherapy. And she heard about this new class of therapies called immunotherapies. Immunotherapies can be very effective for lung cancer patients, but also can be very toxic, and it's also very expensive. And she sat down with her physician at the University of Vanderbilt Medical Center in Nashville, Tennessee, and she asked him whether this therapy is good for her or not. The only thing that they can do at that time was a biopsy to understand whether she expresses the target for a certain class of immunotherapies called immune checkpoint inhibitors. And she was expressing PD-1, which is a target for some of these drugs like Keytruda, if you guys heard about Keytruda. But she also heard that, you can have myocarditis from Keytruda or pneumonitis, and she had to figure out $100,000 budget for this therapy for 1 year. So she was really torn, and she had a clear question to her oncologist. What is the chances of me getting a benefit more than the risks of this therapy? Would I die from this therapy or actually live longer from the therapy? And at that time, there wasn't a lot of answers except, the meta-analysis around survival rates of immuno-oncology around 50%. But there wasn't really a lot of information that can be shared with her around her personal risk of developing certain toxicities for her to be able to really make a decision together with her oncologist. Sarah ended up getting immunotherapies, and she developed pneumonitis, which is a toxicity that I think happens to 10% of immunotherapy patients. And she had to stop her treatment because of this, and she died from her pneumonitis complications after that. So her story is not a unique story, actually, along with other patients who receive target therapies today are motivating us to think about developing some tools as a biomarker for response, as a biomarker to predict not only efficacy of new therapies, but also toxicity. So can we really help other patients like Sarah understand their potential response from a certain expensive therapy and their risks and toxicities or not? This is what I'm going to answer at the end of this presentation. But let me first take a step back and maybe just make sure that we all speak the same language when it comes to the definition of AI and machine learning, and talk a little bit about why do we care about AI in healthcare and oncology. And then I will share with you a use case example that we worked on with the University of Vanderbilt Medical Center to develop some AI biomarkers to predict response and toxicities. And then I'm going to close with some key considerations if you are starting an AI program or already adopting an AI program in Egypt. So first, and I'm sure this could be redundant for some, so I'm going to just touch on this very quickly. The definition of AI is really the development of computer systems that are able to perform some tasks that are usually requiring human intelligence. So for the first time, now there is a machine that shares intelligence with us human beings. And they can do tasks such as visual perception, speech recognition, decision making, translation between languages. So you talk to Siri or you talk to Alexa, that's an AI algorithm behind the scene that can recognize your speech and help you achieve some tasks. Or visual recognition, that's why you see a lot of advances in imaging and in pathology today, because it really builds on that visual perception capabilities of AI. But why are we really excited about AI in the last 5 to 10 years? Actually, if you look at the literature, AI concepts like machine learning has been there since the 50s, but actually we weren't able to bring them to reality because we didn't really have a lot of data. So the advances that we had in memory, our ability to store large data sets, has been a great driver for AI in the last 5 to 10 years. Being able to store terabytes of data is actually something we weren't able to do 20 years ago. If you remember, if you are buying a computer or using a computer, you would store a couple of gigabytes, you would have a floppy disk of less than a megabyte of data. Now you can really store large amounts of data that potentially you can use. And also computation has been advanced in the last 10 years significantly. Now you have supercomputers, you have higher speeds of computer that can help you process this information much faster. But probably more importantly than these two dynamics is actually the learning aspect of AI that is really making the difference versus traditional digital technology. And the ability of AI to not only learn from the initial data set, but continue to learn as you use it is actually what's making AI very interesting. And this makes me, I think, transition into machine learning. Think about machine learning as a tool in the AI toolbox that I think we use the most in healthcare today. And machine learning is basically the study of algorithms that uses data to improve through experience. So algorithms usually are relying on code. So you write a code, you tell them exactly what to do to go from point A to point B. And if you use this algorithm 10 years from now, it's going to do the same job. Machine learning is different. You give it data. Its code is actually data. And then if you use it more and more, so you give it more data, it actually improves over time, which is really fascinating. The third concept I want to touch on quickly before I transition into why AI in healthcare and how machine learning actually works is actually that AI still is very narrow. So despite all the excitement, when you look at the AI that we have today, is actually solving a certain problem, a very narrow problem. It is not very general. You can't really give AI today a general problem, especially in healthcare. But also outside healthcare, you have to really narrow down your question that you're trying to answer. You can't really predict a tool to predict all cancers today. But probably if you narrow the question down to lung cancer in a certain population, you could potentially get an answer. So it's a very important concept because people are very excited about AI, but I don't think they appreciate the fact that it's still a very, very narrow tool. It's very powerful, yet a very narrow tool. And it's important for you to keep this in the back of your head while you're developing new AI tools. The other concept obviously is data, right? Without data, you don't have AI. So it's the engine for AI, it's the new oil as people talk about it. So if you don't have data, you can't really build a machine learning or algorithm because this is your input or your new code for these algorithms. So what are the machine learning capabilities that we are currently using in healthcare? There are a lot of capabilities that we're currently using that we basically took from other industries. So I'm going to share a couple of examples and then share examples in oncology and how we apply them today in oncology. So image classification, of course, you know this better than I do as a radiologist. This is one of the most advanced capabilities of machine learning, the ability of the machine to differentiate between different images. You use it every day in your iPhone. If you're using your Face ID, you find all the tools like Facebook being able to determine different images and tag people names on top of images. And this same capability, we took it and we started to use it in pathology, radiology, and other image dependent modalities within cancer, and with great success. So for example, detecting prostate cancer now is actually being transformed using AI. So the University of Pittsburgh Medical Center just published a study that they developed an AI tool that can detect prostate cancer with 97% specificity, 98% sensitivity, training an AI algorithm on 1 million biopsy slides of prostate cancer. And not only it can detect prostate cancer, it can actually help grading and all the other features that you need in the pathology side of prostate cancer diagnosis, which is huge. It's not going to replace the pathologist, but it's going to be a great QC tool for the pathologist to double check what they see under the microscope, and hopefully it will save more lives. Actually, there are now studies that are showing AI algorithms detecting more prostate cancer more accurately than pathologists, and catching some missed prostate cancer diagnosis. Breast cancer, there are a lot of publications now on using mammo not only to actually detect breast cancer, but also to predict breast cancer 5 years in advance. So MIT and Mass General Hospital in Boston published in 2019 a study in radiology using mammo images of patients that were diagnosed with breast cancer. This AI algorithm was able to learn the subtle differences, the subtle precursors in these images that can help predict whether this woman is high risk of developing breast cancer 5 years from now or not, which is huge when you think about it, because this can transform the world of screening and the world of catching breast cancer earlier in the pathway. Lung cancer as well, MIT and MGH again, they worked together on using CT screening images to actually predict lung cancer 6 years ahead of an actual diagnosis, which is huge when it comes to lung cancer detection, using thousands of smokers' CT datasets. They were able to predict lung cancer 6 years in advance using these images. So these are all applications that are happening today, leveraging this image classification technology. And that's why you see a lot of hype around pathology and radiology, because you guys have images. So that's a great starting point to develop AI algorithms in healthcare and in oncology in particular. The other cool capability that we use a lot is predictive models. And you use predictive models a lot today. If you're using your Uber or Google Maps, you find them giving you directions on where to go based on your history. So every Saturday I open my Google Maps, it tells me you're gonna go to this place, because every other Saturday I used to go to this place to drop my daughter into her practice. So the same technology now is being used to actually predict certain outcomes in cancer. So one of the examples is the Imperial College of London actually just published a study on their ability to use patient information, not only images here, but actually a collection of patient data, electronic medical record data plus images, to actually predict non-small cell lung cancer recurrence and stratify patients based on the risk of recurrence, which is really going to help monitor the high-risk patients more closely, but also maybe save monitoring costs for the lower-risk populations. So I want to touch base quickly before I go into deeper into one example on how machine learning actually works. So what is this black box, as some people call it? First, you have to really have a clear problem statement that you're trying to answer. That's the starting point of any machine learning algorithm development process. And once you have this problem statement, you need to find a historical data set, whether it's an imaging data set or electronic medical record data set, that is relevant to that problem. And once you have this data set, which is not as easy as it sounds, because data, if it is not images, it is not usually ready for algorithm development, and it needs a lot of curation or structuring, because you really need structured data first for the AI algorithm to start working, for the data scientists to start mining this data. And then once you have this data set structured, then you can start applying a certain capability within machine learning to develop an algorithm. Basically, you're learning about relationships within this data. You're trying to figure out if BMI plus smoking status can actually help us predict lung cancer, for example, or if a certain demographic information can help me understand the risk of the therapy and the risk of developing stage 3 diarrhea from this certain therapy, for example. And then you have a model. Based on this algorithm, you have a model, and the model is basically storing and applying these relationships in real life. You give this model new data, whether you're using it or training it more, right? And it gives you a prediction that improves every time you use the model. This is simply how machine learning works. So it all starts with a clinical problem statement and a structured data set. And that's why it's very important for any successful AI project that clinicians work very closely with the data scientist. If you have data scientists only working in AI, we don't see success. And if you have clinicians only working on it, you don't also see success. It only is successful when you have a clinical team that understands the unmet medical need they are trying to solve for, together with an AI team and data science team that is understanding how to manage the data behind that problem statement. So why AI in healthcare and oncology then, based on what we talked about? I think there are 4 challenges that we're really trying to solve for using AI. AI in the end is not the goal, right? It's just a tool that we're really trying to use to solve the problems that we all face in the healthcare system of today. And there are really 4 problems that AI can help and proved already that it's helping to solve. One is the cost challenge. And if you look at the United States today, for example, we have $500 billion of waste in the US healthcare system. And AI can really help us optimize a lot of processes and save a lot of waste within the process. When you look at drug development, and this is very applicable to oncology, I don't know if you guys know this, but 95% of clinical trials actually fail. 95%. So only 5% of clinical trials actually succeed, and that's why the cost of bringing a new drug to the market is very expensive. It's $2 billion. And AI today is being used to help design clinical trials better, especially in the world of oncology, to help recruit the right patient for the right clinical trial, to help even preclinically identify the right targets so we can maybe optimize the investment. Because if we can move this number slightly lower than $2 billion, this means direct saving in the health system and potentially in the patient pocket. Quality. So in the US alone, 100,000 patients die every year from therapy adverse events. So Sarah's story that I shared in the beginning is actually not an exception. A lot of patients die from therapies today. So how can we predict adverse events and toxicities better? How can we reduce error? And there are a lot of AI tools today, and I'm going to share with you one of these examples that we developed with Vanderbilt that can be used as a marker for prognosis, response, and risk prediction. Access. So access is a big problem even in developed countries now. We have a shortage in almost every specialty in the US. We don't have enough technologists to run the available machines. And I think you guys know the access issues we have in Egypt as well. So at least half of the world's population today cannot obtain essential health services. And with AI automating a lot of the lower value activities, it may allow for more time with the available physicians to actually treat patients and improve our capacity to actually treat more patients. And last but not least, and this is an opportunity and a challenge, if you look at the data that health systems generate today, in the US, hospitals produce an average 50 petabytes of data per year. Huge amounts of data. If you look at individual patient level, there are now hundreds of data points on a patient, especially after developing new genomic testing tools. We have a lot of information about the patient, but actually the clinician still uses very little of this information to actually make a decision and plan for therapy for these patients. And 97% of this information goes unanalyzed or unused, which is really a shame because you have data, you have more data on the patient, but actually you cannot really make a good use of this data. So AI can potentially help us really aggregate these disparate data sets, integrate the data in a way that we can digest as human beings, and maybe make better decisions using more data points on the patient than the number of data points we currently use. Right, so let me deep dive in an example here on how can AI enable precision health in oncology. Precision health is I think the new hype in healthcare systems today, and is believed to be a game changer in terms of improving outcomes for patients. So when you think about cancer, you guys know not every patient is the same, right? So there is no one size fits all when it comes to therapies. And there are a lot of factors that can contribute to the uniqueness of these patients. Some of them are demographic, some of them are genetic, and some of them are related to the external environment of these patients. And ideally, precision health means you want to stratify these patients based on these factors. So you can customize treatments and diagnostics based on the factors that contribute to the uniqueness. So instead of seeing all of them blue in the left-hand side, you can see them differently and customize therapies and treatments for them differently. So let me deep dive on an example where we try to really make precision health a reality in oncology. This was a collaboration that started 5 years ago between GE Healthcare and Vanderbilt University Medical Center in Nashville, Tennessee, based on the patient story that I shared in the beginning. And the question that we posed was, can we predict the efficacy and toxicity prior to immune checkpoint inhibitor treatment, which is now becoming a very powerful treatment in lung cancer and melanoma and other cancers. But it's a very expensive treatment and a very toxic treatment. Not every patient responds, and a lot of patients actually die from the therapy, not from cancer. Can we predict outcomes in a way that can help the clinician make a better decision, help patients make a better decision when they choose these effective yet toxic therapies? So we started by laying out the project vision and objectives. We were really lucky to find a good data set for this at Vanderbilt, 3,300 patients who received immunotherapies. And we started by curating the data, which is a very, very manual process still, although there are some tools now that can help automate curation. But this is, I would say, the bottleneck of developing an AI algorithm. And we started training and validating the AI models after curating the 3,300 patients, extracting the clinical variables and the toxicities from the clinical notes. I should mention that most of the valuable information are not really structured, as I mentioned. It's really in the clinical notes, in the text. So having a strong team of bioinformaticians who understand what we're looking for is very important in terms of curating the data and handing the data scientist a clean, structured data set that they can mine and build a model based on. And we're trying to answer two questions. One, what is the probability of efficacy of an immunotherapy response? What is the probability of certain toxicities? We focused on the toxicities that matter the most, such as pneumonitis, which happens to 10% of patients. We focused on toxicities that can actually lead to stopping the therapy. And the objective was to help clinical trials recruit the right patient. So this was huge for pharma companies who are working on immunotherapy clinical trials, because you can really exclude or include patients based on that prediction if you have high accuracy model. And also we wanted to really use this in the clinic to personalize patient management, not necessarily to exclude patients from a strong therapy like this, but to understand the risks and maybe have some mitigation strategies for toxicities for patients who have high risk of toxicities. And of course, there was a big exchange of de-identified data between GE and Vanderbilt, and we started to work on toxicity first. And as I mentioned, we narrowed down this to certain toxicities, focused on pneumonitis, colitis, and hepatitis. Pneumonitis happens to 9% of the patients who receive IO, and we were able to build a model that has a 75% accuracy for these three toxicities in average. What does it really mean? So if you built a model to detect pneumonitis with 70% accuracy, what does it really mean? If you today have a clinical trial or 100 patients who are receiving immunotherapy, you will have 9 patients who will have pneumonitis. These 9 patients would have to stop the therapy at some point and will not benefit from immunotherapy. If you use the AI tool, you actually can drop this number to 4. So you would save 5 patients from a toxicity that would lead to stopping the therapy. You would actually, if you have a clinical trial, you would have a higher degree of success for your clinical trial. That's why pharma is very interested in using this model today to recruit patients for their IO clinical trials. We then shifted our focus to efficacy. Can we actually predict efficacy? Which is actually a harder question than toxicity, because the efficacy endpoints is very hard in oncology. There are 2 endpoints that clinicians usually expect in a clinical trial. One is overall survival, and one is progression-free survival. And we didn't have both in the data set. So we had to really sit down with the oncologist first and understand what is a good surrogate, or what is a good proxy of outcome measures that we could use as a proxy for OS and PFS. And we decided to use time on IO treatment and also the death data as an OS proxy. And I'm sharing this with you guys to emphasize the importance of working closely with your oncologists and researchers on the clinical side to actually develop the right endpoints for these algorithms, because without making them relevant to the clinician, they are not going to be adopted at the end. So we were able to actually predict 100-day survival, 1-year survival, 3 and 5-year survival with 70 to 80% degree of accuracy using features in the data set like age, blood lab measurement, chemotherapy indicators, and some other cancer codes in the data set. What does it mean again, being able to predict 5-year overall survival? Today, if you don't use this AI algorithm, you will have a 30% overall survival, 5-year survival. So 70% of patients will not benefit for 5 years from this therapy. If you use this AI algorithm to recruit patients for this particular therapy, you actually can improve that 5-year overall survival to 43%. So you can get a 13% increase in 5-year overall survival, which basically means you're choosing the right patient for the right therapy, which basically means you're making precision health a reality for these patients. We're getting closer to it. So the question then became, how can we validate this? Because you developed it on 3,000 patient data set. This doesn't mean that it can work outside Tennessee. If you take it to Boston, if you take it to Germany, is it going to produce the same result? So we started to work with another university in Germany, University of Essen, to actually validate this on their data set. Luckily, they had 4,000 patients who fit the criteria, and we worked with them. And this is what I'm most proud of this project, is that we developed a similar level of accuracy on a different data set in Essen versus what we developed with Vanderbilt University, which means that your model is actually reproducible and accurate. This is not the end, though, because you still need to validate it, and you still need to start using it with cautious, because every data set can be biased with every model can be biased with the data set that it was used to develop.
Dr. Mohamed,
so,
can we expedite, please? Yes, thank you. We have the opening ceremony, so we're short of time.
No worries.
Thank you.
Shall I close now? I have 1 page left, or shall I?
Thank you. Okay, we can listen to this page.
All right. So I think just to close on this, I wanted to really share with you guys, if you are building an AI program in Egypt, I think 4 things to think about. AI strategy. Make sure your problem statement is narrow and focused on a clear unmet medical need and a clear endpoint. Focus on the low-hanging fruits where you have data sets and capabilities. And when you think about data, 4 problems that you really need to build your data management programs on. One is data integration, the identification of patient information, data curation, and sharing. And for curation, you really need to think about bioinformaticians and data scientist capabilities. Or you really need to think about partnerships to build capacity if you don't have capacity in-house, in Ain Shams or in Egypt in general. And then once you have a model, if you think downstream about adoption, 2 things we really need to consider. One is, can we validate this information? How can we validate it? Because every data set has a certain degree of bias. And then how can we integrate this within the workflow so the clinician can use it effectively within their day-to-day without adding more burden on the clinician, but rather helping the clinician do the job better. So with this, I would like to thank you, Dr. Aya, for inviting me, and I hope this was helpful, and thank you very much.
The topic is very interesting, and we are all eager to hear more from the speakers. Yet, please, the coming speaker and the coming speakers, all we have to stick to the time estimated, because we have an opening ceremony and we should start on time. The coming